Okay. All right. Any so again, this session will be to cover the content on pertains to renal or kidney disease, including the acute the urolithiasis, the UTIs and AGN and pyelonephritis, and then a little bit of maybe towards the end about the renal transplant, given that there was a guest speaker who talked about the donations and transplantations, and so maybe just go over the concept of transplantation of for the kidneys. Now, before we start the kidney disorders and the treatment and all of that, so how would you assess kidney function? Well, how, in terms of how would you know that this patient has a kidney problem? Things that pertains to kidney assessment findings that may indicate that this is a renal issue.
Does the patient have edema?
Edema, yeah, fluid retention that could indicate that it's either cardiac or maybe kidney or liver. So we don't know. So that would be one of, we have to sometimes to go into further step to do differential diagnosis. So that will be one of the things, right? So of the assessment findings is that fluid retention or edema, especially in lower extremities edema, or generalized edema like anasarca, which is generalized edema. Can, that's usually sometimes it will be may be a resultant effect of kidney dysfunction. What else?
Professor, I'm thinking if there's like protein in the urine, like the stuff
Absolutely.
be
There
in the
should be
urine.
there should be no protein in urine, given that the protein molecule is a quite large molecule and shouldn't be shown, in the urine. So it should not pass through the glomeruli in the urine. So protein presence in urine, proteinuria, it's I would say, significant manifestation or significant finding of a kidney in a kidney disorder. So that may indicate that there's something wrong with the kidneys, maybe like glomerulonephritis, pyelonephritis. It can or nephritis or nephrotic syndrome. So there is protein in urine that's not shouldn't it's not like a usual finding in a healthy kidney or healthy person, like a person with healthy kidneys. So protein in urine, yes. What else? Kidney dysfunction. How would you indicate? Like list the things that you may. Yes, go ahead.
The creatine, the GFR, and the bone.
Creatinine will be high. The bun, right? The blood urea nitrogen will be elevated, also high. What else?
Hypertension, I'm thinking.
Yeah, blood pressure will rise because that's kind of a reciprocal relationship between blood pressure and kidneys. Kidneys affected, blood pressure will go up or rise, and then patients with hypertension, they could end up with the renal damage or renal failure. So it's kind of both reciprocal both ways between the kidneys and blood pressure. So hypertension is a number one, I would say, risk factor for renal failure. GFR, right? So the GFR, so it would be the most reliable and valid testing renal function test that we rely on more than even bun and creatinine and evaluating the kidney function. So we'll go over the kidney function in other slides. I will go over that as well. So, but these are the protein in urine, like fluid retention, low GFR, high bun, high creatinine. All of these symptoms are significant that we kind of take it seriously in terms of that could indicate there is a renal dysfunction. So the first question here is nurse is taking the history of a client who has been diagnosed with renal calculi. So the first diagnosis disorder we're going to cover is the urolithiasis, like cholelithiasis, which is stones in the gallbladder. Now here we're going to cover the stones as being developed or being formed within the kidneys or the renal system or urinary system. So this is called urolithiasis. In urolithiasis, the kidney stones or the stones, it can be formed or developed inside the kidneys, within the kidneys. There's going to be sometimes move and travel down the ureter or down to the bladder. So it's a kidney stone. It's called urolithiasis, stones within the urinary system. So patient has been diagnosed with renal calculi, or calculi mean lithiasis. Lithiasis, calculi, the same thing, which indicates stones. Now, what information in the history, this pertains to the 235 course, the health assessment course, which information in the history should the nurse identify as precipitating factor? I'm sorry, not this one. This is a question more about the risk factors. There is another question that pertains to the 235 assessment course, but this one more of risk factors that may precipitate and result in or cause and that make the patient develop the kidney or urolithiasis or kidney stones or calculi. There are certain risk factors. We're going to cover these factors in a minute, but this question is kind of preview, to give you heads up of what could be the risk factors and the most serious ones among we have 4 options here. So is it the increased incidence of UTI or drinking about 6 to 8 ounces of milk daily or recent fracture of the femur? And the patient has prolonged bed rest. So patient on a weeks or even sometimes months of bed rest because of recent fracture of the femur. So that's immobilization for long-term immobilization. And then we have a high intake of citrus fruit and high fiber carbs. Which one do you think is the highest in terms of risk factor that made or predisposed the patient to develop urolithiasis, calculi, kidney stones? It's not an easy one. It's really needs to have to rethink about every single option and element or distractors. We have few distractors that are not easy to eliminate.
Professor, is it number 2? Is it calcium?
Okay.
Yeah.
Now, number 1, let's go with number 1, increased incidence of UTI. UTI infections usually do not precipitate problems with kidneys, has almost nothing to do with kidney stones or renal calculi or urolithiasis. But however, the presence of it's the other way actually. Just remember this. This is very important to write as a note. Write down is that the UTI is the precursor for. I'm sorry, the stones. Sorry, the other way. It's the kidney stones or calculi or urolithiasis may predispose patients to UTIs, and that also happen. I had this kind of scenario. I would say maybe 12, 13 years ago. I have a history of kidney stones. So my buddy is kind of build stones as I don't drink enough water, so I have to sometimes I feel that I have flank pain and I have to run and drink. So we have that feeling that when our kidneys are going to build some kind of start building these stones, we have that feeling of that kind of slight pain, that minimal pain. So we will drink fluid and then we're fine. So is kind of your body said there is a genetic predisposition, number 1, and second is the dehydration. Most likely is going to be the risk factor for people to develop stones because the concentration of urine that would predispose patients to stones and that make it easy for the stone to develop because of the over concentration or the over concentration of the urine. So decreased fluid intake. So first of all, number 1 is most people have genetic predisposition, familial factors. Family, it runs in the family. So number 2 is the fluid intake. That's, I would say, the highest kind of problem. And then, so I developed that kidney stone. I ignored that. So I kept going, working, and I never. So it was even the stone was so tiny. I had developed that more than 10, 15 times in my life. However, that incident was so serious is that the small, tiny kidney stone, 3 millimeters stone with some minimal pain or maybe moderate, I would say moderate pain. I tolerate that, did not go to the emergency, did not even seek medical attention. Now, within 3 days or 4 days, I would say that, I developed what's called so I had a stone, developed the UTI. I ignored most of the UTI symptoms. to the point that I developed the fever, all the systemic manifestations of sepsis, which is so UTI. So stone can lead to UTI. It's not that UTI can lead to stones. You got that one? So number one. So that's why I ended up like in the medical unit on antibiotics, IVs, and and the IV fluids, because I developed the what's called urosepsis, a septicemia, because due to the or in resultant as a resultant from that UTI. So it was it's a stone led to the UTI, and then septicemia or septicemia. So I was septic at that night when I was in the emergency department, and I was still have to be in the medical surgical med-surg unit for 2 weeks being on IV antibiotic. So again, so stone can lead to UTI. So number one, ignore that, delete it, eliminate. Number two, drinking 180 to 240. So it's 6. So drinking milk daily, even that amount, it doesn't affect or result in kidney stones. So another distractor. So it's number 3. I'll explain why. What about number 4?
Professor, isn't high fiber good for you?
Yes, exactly. So 6 to 8 ounces of milk is not excessive and doesn't predispose client to the kidney stones or calculi. The increased intake of citrus and high fiber carbs is good for the nutritional needs. It nothing to do with stones or developing the urolithiasis. But why recent fractured femur and prolonged bed rest is the highest risk for this, for the specific patient to develop the kidney stones? Most of kidney stones are consist of what? Calcium. If you go to
So
sorry, I'll just flip the slide. Yeah, if you go to the kidney stone, in terms of the composition of kidney stones or urolithiasis, you'll find the kidney stones are most of the stones are consist of calcium. So either it's calcium oxalate or calcium phosphate. So we have here calcium, calcium phosphate, calcium oxalate, or calcium urate, which is uric acid. There are different types of the kidney stones, and these are the 3 main components in the in dietary recommendations when we teach and give tips to the patients and teach them about the food nutrients or things to be restricted and to restrict like nutritional restrictions to prevent kidney stones. You have things so each kind of person has their own I would say different type of stones. Like mine is always oxalate, so I know what type of food I should be avoid, not to avoid completely, but not to consume in moderation, to just restrict it in your diet. Once a week, once a month, that's fine, but not a daily ingestion or taking that kind of food on a daily basis is will result in a kidney stone. So oxalate, so patients should know if they know that their body developed a oxalate stone, we will tell them about and teach them about the different types of food they should be restricting in their diet, because their body is going to develop stones because it's their body developed that type of stone. So again, if that's the case, if the oxalate, then you have specific type of food should be restricted. If that patient has a calcium, either calcium oxalate or calcium phosphate, same thing. Or if that's a purine stones, then they have a specific type of food that should be restricted because that's purine type. So there are different types of stones in which that the patient should restrict in their diet based on the type of stone that their body would develop. And how would they know that their body developed that type of stone? How would they know? Like mine is, I know that my body developed what is called the calcium oxalate stone. I know how it looks because I passed it a few times. I know how that stone would look, and then I would restrict that food that is high in oxalate in my diet as much as I can. So how would you know that that patient's body may develop that type or tend to develop that type of stone? It's calcium oxalate, calcium phosphate, or calcium or purine or urate.
I know for the purine, once I did a test, there was crystalline in my urine, so my doctor told me to avoid eating food that was high in uric
Right.
acid.
From your urine, you can do from the just rare urinalysis if there's some symptoms, but most of the time when patient had developed or they experience or undergo or experience like that episode of kidney stone being collected and then being treated for the kidney stone, urolithiasis or calculi, and then they pass it, they will strain the urine. They will, if they go for lithotripsy, like crushing the stone with with that ultrasound machine, or if they go if they pass it, and usually most of them they pass it without knowing, so they'll never. There's no way they can strain it. But if they have been treated with some type of interventional treatment or technique, then they would know that they will pass the stone, especially with lithotripsy, which is this stone crushing kind of ultrasound machine. So they will go home and they start straining the urine, and once they catch the urine, they will send it to the lab, and the lab would analyze it. So that's how usually we will analyze kidney stones. So let's go back to the risk factors. So the first of all, we said urolithiasis, kidney stones, calculi, the same things, same terminology being used for kidney stones. So the 75% of stones, as we said, contain calcium, either calcium phosphate or calcium oxalate. And then we have the other percentages for the other types of the stones, like uric acid and cysteine will be way lower percentage. But most of patients, they tend to develop the kidney stones from the deposition of calcium, either calcium phosphate or calcium oxalate. So most, again, the tendency that, so patients usually have tendency, their body tend to develop kidney stones. Sometimes we call this familial factor, genetic factor, predisposition, but their body tend to develop that, the stones. So once they develop once, they should be careful to prevent it prophylactically, fluid intake. If they have known that what type of stones their body would develop, then they will be restricting that that food from their or diet recommendations to be restricted from their diet and so on. So activity also would help. So back to the question, patients who had developed the stone was number 3, because immobility is a significant factor that may predispose patients, especially if their body tend to develop stones. They have a history of stone, right? Of calculi, renal calculi. So why immobility, or what would make immobilization, patients who like immobility, to increase tendency or predisposition to kidney stones? The linkage here is that in pathophysiology, remember that the immobility makes the bones to lose calcium, and calcium will travel, like being what is called it's called bone resorption. Bone resorption means calcium leaving the bones into the bloodstream. So we have calcium being released from the bone into the bloodstream, and we have more calcium deposit, will deposit in the blood or travel to the blood and then to the urine, and that will make it high likely that, or risk will be higher because of that immobilization and calcium or bone resorption and calcium concentration. So there is high calcium concentration in the blood because of the prolonged bed rest. So immobility, just think of inactivity, especially here with the immobility, prolonged predispose this patient to develop kidney stone. So that's a risk factor for kidney stone. So,
Professor,
yes.
sorry, quick question. Does the broken bone have to do with the kidney stones?
It's not a broken bone. No, nothing. It's the immobilization, prolonged bed rest. Yes, the prolonged bed rest. Yeah. So immobilization and activity for a long time could lead to kidney stones. So activity, fluid intake, the food restrictions, specific guidelines. They have to follow that. Have known or given that patient had known that the specific type of kidney stones, then they will restrict their food from I mean the specific type of food should be restricted. Then they would that will decrease the likelihood or the risk factor for stone to be developed for that. So that patients, they know themselves, they know the type of stone, they know so activity and fluid. So the decreased fluid intake, dehydration, and stone formation. Found a good discussion on that for this concept, and it's one example of the metabolic problem causing stone formation begins when excessive amount of calcium are absorbed through the intestinal tract, and if the fluid intake is poor, like low fluid intake, such as when the patient is dehydrated, this is going to result in supersaturation of the urine, and that will make it or increase the risk for calcium combining to another electrolytes and result like oxalate or phosphate, and it will result in more stone formation because the calcium deposits with other electrolytes like calcium with phosphate or calcium with oxalate or calcium with other, so that will result in a stone to form. The pH also may affect the kidney stone or become like a risk factor for kidney stone formation. So we the high acidity or highly alkaline urine both may predispose patient to specific type of kidney stones. Urinary stasis, like the patient has a renal immobility, one of them, inactivity, immobility, or immobilization, and renal stasis, kidney, like if there is a obstruction to the urine flow or flow of the urine within the, like a something obstructing the urine either within the kidneys or in the ureter, that's could result also in kidney stones. There are some medications. One of the medications that may predispose patients to kidney stones is the acetazolamide, which is Diamox, which is one of the medications that we covered in glaucoma. But here it's the tablet form. It's the acetazolamide Diamox, which is a medication for diuresis, diuretic medication. So calcium by itself, we shouldn't be looking at calcium just as so. In other words, that a diet high in calcium is not believed to cause stones unless a metabolic problem or kidney tubule defect also or already exists. So calcium by itself, again. So how many times, how many times you see people, eat a lot of like, cheese and calcium and all of, so they don't develop stones. So it is not just the stone itself. I mean, the calcium itself as electrolyte, but again, the patient usually have a metabolic problem, or their body tend to develop they have a tendency to develop the stones, genetic or familial or any other kidney problems that make it would add to the so calcium by itself, it's not a high risk factor or a risk factor for kidney stones, but it's other metabolic problems that may predispose patient to develop stones. So genetic, they found a lot of, in terms of genetic genomic considerations, there was like more than 30 genetic variations they were found to be associated with the formation of kidney stones. So there is a high genetic predisposition to the kidney stones. And there's a good section, or there's one of the slides in the other PowerPoint slides talks about this, about the connection between or correlation between genetic predisposition and or genetic factor and kidney stones. And also there is on the same slide, you will find some or verbiage like content or something about the variability of or the geographic area and as a risk factor and kidney stones, like people who work and who live in certain geographical locations, they'll be at risk more than others to kidney stones. You'll find that also in that same slide on the other side of PowerPoint slides. The incidence in minutes more higher higher in men than women. There is a stone that is called Strovite stone. Sure, if I have a slide. Yeah, the Strovite stone, which is a complicated stone. It's a stone that consists of 3 electrolytes: magnesium, ammonium, and a phosphate. That's called Strovite stone. It consists of about like 15% of people are affected with stones. However, that so in general, we can say that the incidence is higher in men than women for like including all different types of stones. But when it comes to the Strovite, we found that the Strovite, just from prevalence, it's nothing like there's no specific reasons or causes or predisposing factors or etiologies. But they found from the prevalence is that the Strovite stones, they are higher or they are twice as common in women than men. So the question here, before we go to the question, let's just talk about the clinical manifestations before we go to the urolithiasis. When we say urolithiasis, what do you think will be the first or most prominent manifestation and sign or manifestation of kidney stones? People have been experiencing kidney stones. They have been disclosing or said something about it. About
Flank.
manifestations.
Is it flank pain?
The flank pain. That's how it starts actually. And that's again, when I don't drink like enough fluids or water that day, I would feel that kind of flank pain starting as if the stones is being formed, is kind of starting to form. So if you drink water, you can flush it, you can. So I would say the highest risk factor is the oversaturation of urine. So this is called renal colic. So when anyone who developed kidney stones, so this type of renal colic, which is severe pain, flank pain, and most of the time it's associated combined with nausea and vomiting, pallor, diaphoresis. That flank pain is excruciating pain, very kind of severe to the point that the patients cannot tolerate that pain. It's worse than even the acute MI. So when patients develop this kind of severe pain is when the stone is stationary, like localized, it's not movable. When it starts moving, that's when the patient starts to feel or experience that severe pain. So or when the ureter is obstructed, especially with kidney stones, that's when the patient will develop that renal colic. The patient also will develop symptoms similar to the UTI, like dysuria, frequency of urine, sometimes even oliguria or anuria, frequency, urgency. They kind of feel that they want to go to the bathroom. To avoid, but nothing comes out. So, so that's an urgency. And sometimes hematuria, especially with the stones is moving, then the stone is going to hit, the mucous membranes and result in blood tinged, or the blood would be mixed with urine. So that's called hematuria. So which nursing observation indicate that a male client with kidney stones is experiencing renal colic?
One.
Right. So most characteristic symptom of renal colic is sudden severe pain. And patient, as have mentioned earlier, may exhibit also nausea and vomiting, pallor, diaphoresis during the acute pain episode. Stress incontinence, it's not associated with renal colic. Hematuria and burning on urination are associated with UTI. So patient may develop hematuria at some point, but most of the time it's when the stone kind of moves down the ureters, that's in the kidneys. So diagnostic, most of the cases would start, or like scenarios would start with urinalysis, and then we will do the CBC, KUB, which is kidney ureter bladder, That's kind of X-ray, and then CT scan, IV urography, and renal ultrasound. Not necessarily we have to do all of them. Sometimes we'll, with the first two or three suffice because we can confirm it from with symptoms. So this is the slide in which that will present the obstruction from the kidney stones on the right side. The other half, which is left side of the slide, you will find the urine retention. When the urine retains in the kidneys, that is called, which is right here, this one, this is called the hydronephrosis. Actually, both of this is hydronephrosis because the urine is being collected within the kidneys. There is some obstruction right here, stone, obstructing the urine. Could be like, at the pelvis of the kidney or right next to it. So either in the pelvis or next or the beginning of the ureter, that still is going to result in hydronephrosis. Now, this one is a hydroureter because the stone is down the ureter, so the urine has been collected within the kidneys, but most of it within the ureter. So this is called hydroureter. This is hydronephrosis. This is very dangerous because that's going to result in a severe UTI, and patient will develop the obstruction, urinary obstruction. And at some point, we have to insert the urostomy catheter to drain the urine. Most of the time, they will treat the removal of the kidney stones, and then right after that, they will insert the urostomy tube or catheter to drain the urine. These are some of the stones being presented, and one of them is a huge stone. This one is a huge stone that looks like it's struvite stone, or even stag. It's called, this one pretty much is called the staghorn. The staghorn, which is the stone that's going to a stone that is it's a huge and large, and to the point that this stone will form, taking the curvature and the I would say the curvature of the kidney, the calyces and the kidneys. So it will be very difficult to pass. It will be kind of sticking to the kidney and take the curvature of the kidney within the calyces, and it's very difficult to detach and be or to pass it in other ways. So this is called the staghorn stone. So the other types of stones. So diagnosis, we said that the lab assessment of a UTI is urinalysis. So when we look at, so let's stop here for the lab in terms of when you do urinalysis and trying to diagnose if that's the stones, urolithiasis, kidney stones, or calculi, or to find out if that's a UTI, because sometimes, as we said, that the kidney stones will predispose patient to develop the UTI. May take like a few days, a couple of days to develop the UTI. So, which of the following, or as you review the findings in the urinalysis findings or urinalysis like in the results, the UA results, which one should indicate that, or it's called alarm and flag, like raise the flag that this is a UTI. Specific like finding from the UA urinalysis that may indicate the presence of bacteria. There is a UTI. And sometimes we would even confirm it with manifestations, and the urinalysis results would confirm the UTI, especially with older adults, and we'll treat patients based on manifestations and associated with lab findings from the UA urinalysis, without even doing the CNS, which is culture and sensitivity. So what about the UA urinalysis? Which one should be a significant finding from the urinalysis results that may indicate a UTI?
Protein?
Protein is a finding of kidney dysfunction, like acute kidney injury, chronic kidney injury, end-stage renal disease, nephrotic syndrome, or acute glomerulonephritis, or pyelonephritis, but not the UTI infection. Leukocytosis, white blood cell, would be extremely high in the urine. And leukocytosis, what is called leukocyte, especially leukocyte esterase. Whenever I see leukocytes or white blood cells are elevated in the urine, or leukocyte esterase are elevated also or present, because these are the detached pieces or fragments from the white blood cells in the urine that indicates which is their presence in urine. It also indicate that patient had developed UTI. This is even before we go to the higher level of diagnoses, which is CNS. So you collect urine, clean cache, right, specimen, sent to the lab, your analysis for UA, just UA. And maybe another, or the same, if that was a sterile technique to collect or to obtain this specimen as a sterile technique. Using the sterile technique, you can also ask or request for a CNS. You can do the UA/CNS. So your analysis, and then we can also ask for you at CNS. CNS indicates, so your analysis will provide you with with findings or results and like red blood cells, white blood cells, cast, hyaline cast, sediments, all of these things. Now the CNS. There are findings from the CNS, which is culture and sensitivity. It takes about a few days. You have to wait like 3-4 days to receive the final results of the CNS. But the CNS is more of confirmatory diagnostic test, because it will provide us with a specific type of. They will isolate the organism, the microorganism. They will say that there is more than 100,000 CFUs of bacteria, and they will identify the type of bacteria. Like most of the time, it's E. coli, and they will also provide us with a most effective antibiotic. So that's the CNS. When we request for CNS, culture and sensitivity, we are asking them to provide us what type of bacteria, if present, more than 100,000 CFUs, and what type of or kind of like antibiotics would be more effective for this patient. In other words, that antibiotics that are not going to be resistant to this, right, to this bacteria, and they will be more effective. So less resistant and more effective. So the question, this one is about the pain management. So this patient has a renal colic, severe pain from the kidney stone. And patient has all the symptoms of, like, even with colic, with nausea and vomiting. And so what would be the best medication, most effective pain med to be administered for this patient?
Morphine? I don't know.
Yes, we have to give. This is severe pain of renal colic should be treated with narcotic analgesics such as morphine sulfate. You can't, just, it's not going to touch them. Whatever, so if you try ibuprofen or any other NSAID or anything else, it's not going to touch them because it's severe pain. Renal colic, again, sometimes it's even worse than the acute MI pain. So any other medications other than the narcotic analgesics, it's not going to work or be effective for this to alleviate pain for this patient. So urolithiasis, different levels, different types. Pain management. After the ESWL, which is extracorporeal shockwave lithotripsy, ESWL, this is very important technique. It's not diagnostic. This is more of therapeutic technique that I had it done twice, and it's non-invasive. So number one, it's non-invasive procedure. It's a shock wave lithotripsy. It's the machine that is going to be placed next to the patients. I don't have any picture here. You can Google it and find out about the image or picture of the machine. It's like an ultrasound machine. It's like machine is going to be adjacent to the patient's flank area, touching the flank area. Sometimes they are immersed in like in a NUR, sometimes no, without. Now the machine is going to emit the ultrasound extracorporeal shock waves. These shock waves, like ultrasound waves, these shock waves are going to be with vibration. It's going to be like create some vibration. So which in other words that we expect bruises and hematomas, hematoma and bruises after this procedure. So this is non-invasive. Number one, the machine is going to emit the shocks waves and with some type of like vibration kind of motion, and the patient we expect that post this procedure that there will be some bruises or hematomas. That's normal. That's expected. That's not okay. So it's not complication. It's just expected, right, from the actual mechanical utility of this machine. So the shock waves are going to emit this kind of ultrasonic or ultrasound waves to dissolve or to break the stones into small fragments. So into very small, tiny fragments that it can pass through the urine. So patient this patient will be not fully awake, will be like, I would say conscious sedation. They sometimes use propofol, Diprivan. So they will use what is called the conscious sedation. Patient will be like drowsy, but able to respond, like, respond to commands or instructions and follow commands and instructions and able to answer questions, but they will be kind of, sedated, I would say, but conscious sedation. So it'll be like as if they are like deep sleep or kind of, like sleep mode. So conscious sedation for this ESWL, it's non-invasive. It's like an ultrasound machine next to the patient's flank, creating that or emitting these shock waves. It will break the stone into small, tiny fragments. Patient will pass it. So post this session or this treatment modality, then we are going to teach the patient to strain. This is very important. Keep an eye on anytime they will void, urine, then they have to urinate. They will get some the strainers, like filters, and they have to strain the urine after that, because if they catch any of the small fragments that will pass through the urine, then they will collect it in a little cup and then send it to the lab, back to that same like Stone Center in Newark, one of the famous ones, and other places. So you will send it back to the lab, and the lab will analyze it, and we at this point, that's the first time we would know what type of stone patient has, and then we can the analysis would provide us with some information how to restrict or how to prevent prophylactically, how to prevent something to be done prophylactically to prevent that from future incidents or like, events, and especially with the food restrictions or specific type of restrictions in food and dietary restrictions. So and sometimes they will insert the stent, like stenting, and they will maintain the stents for a while, and then it will be removed to maintain the patency of urine flow to treat especially the obstruction. So the ESWL, there will be few questions about the ESWL, maybe like 3 questions. Make sure that you know about the prep, what to expect during, and then the post, mostly post-op, most importantly, post-op or post the procedure. It's not, and again, it's non-invasive procedure, but post-op is very important. So yes, read about the ESWL. So client had a kidney stone removed. A nurse instruct the client to take measures or to implement measures to decrease kidney stone formation in the future. Prophylactically, how this patient or things that can be implemented in their lifestyle, things that should be doing like on a daily basis to prevent kidney stones formation in the future. So which of the following indicate the nurse that the teaching was understood, teaching was effective? What do you think?
Fluid intake, Professor? Don't know.
Most of these questions, when it comes to prophylactically, what would you suggest or indicate or things to be taught to the patients with previous or history of kidney stones? We always teach them to drink fluids, at least 3 liters of fluid daily. That's the minimum for anyone, especially those who have a history of kidney stones. Minimum of 3,000 mLs, 3 liters of fluid should be taken daily. Now, what about number one? Nothing to do, right? So drink sodas or sugar-free, it's irrelevant to the question. Nothing to do with kidney stones. So the most important one is fluid intake, always fluid intake when it comes to prophylactically preventing the likelihood or risk factor or risk of developing the kidney stones, then fluid intake will be the best one. Now, this is a urostomy tube that's most of the time is going to be inserted in case of stones that are large, like staghorn, Strovat staghorn, that's difficult to crush or pass in the through the ureter and the bladder and then the urethra and urine. Then we have to remove that surgically, like open surgical procedure, and then towards the end of the procedure, after they remove the stone, then they will insert the urostomy tube, and that will stay for a few days and then being removed. Now, this client had a right nephrostomy or urostomy, or this is nephrostomy, which is a catheter inserted in the kidneys, and the nephrostomy tube placed after the nephrolithotomy. So nephrolithotomy from lithiasis, in other words, that it's an open, like surgical incision into the kidneys to remove kidney stones. Nephro, kidney, lithiasis, stone, lithotomy, which is open surgical incision. So it's the surgical incision to it's an invasive. This one is an invasive procedure, then, right? So we have to go right into the kidneys and remove it physically, remove the kidney stones. So that's called nephrolithotomy. So after that, they will place or insert the nephrostomy tube or urostomy tube into the kidneys, and that will stay for a while. Sometimes few days, sometimes few weeks. So when the client returns to the room, what is priority nursing action? And this is right after the nephrostomy tube has been placed. After this, the nephrolithotomy procedure has been done and removal of the kidney stones.
I mean, if you said they're gonna insert a tube, so I would expect to make the fourth, ensure that the tube is draining. Really?
That's the most important. Urine, the urine is going to be freely flowing in that urostomy tube. So the failure of the tube to drain freely can result in pain, trauma, wound dehiscence. Remember that wound dehiscence from Adult Health 1, and infection. All these complications can result or be resultant many complications due to that failure of the tube to drain freely. So ensure that the tube is draining freely. That's the most important right post-op. So if an irrigation is being ordered for nephrostomy tube, no more than 5 mLs. If there is an order for that, 30 mLs, that's a lot. So 5 mLs of sterile normal saline should be gently instilled, no more than 5 at any time. So number one, that's why 30 mLs is a lot. So that's incorrect. We will never. I don't think there's any urologist would even order this to clamp or advance, right, the tube. So nephrostomy tube should never be clamped or advanced. Medications to crush or to prevent, like for example, patients with purine Besides medications I would say it will help, like assistive, it will assist in preventing and treating patients with, but it's not like a major, would result in like a major, effect. So it may help or assist in preventing and treating patients with stones, like thiazide diuretics, because that's going to result in diuresis, especially with calcium phosphate patients who had tendency to develop the calcium phosphate stones. And the NutriFast, if you remember that, also we'll cover this in fall, adult L3, about patients with renal damage and stage renal disease on dialysis. They will always, they will be on NutriFast at all times. So all of them, they should be on that medication, which is NutriFast. It will prevent the kidney stones and prevent the calcium deposition. So the other medications like allopurinol and vitamin B6. This is more specific to those who have the tendency, their body tend to develop the calcium oxalate type of stones. So they will be on allopurinol, because allopurinol, it's an anti-gout medication. Allopurinol is an anti-gout medication, and it's also good for patients with uric acid stones, or patients who tend to develop a uric acid kidney stones. Allopurinol will be great for them. So that slide is just provide maybe an image, like to show illustrate how the ESWL, extracorporeal shockwave lithotripsy, would crush the stones and make it small fragments. It's ultrasound waves, but a machine will be touching like adjacent to patient's affected flank, and be touching the skin. So that's why we anticipate some type of, from the vibration of the machine, but it will be anticipate some hematomas and skin. Okay. So that would be hematoma and bruises. Calcium phosphate, again, that's for patient education. That's a huge area in prophylactic, prophylactically to prevent kidney stones. We have to read these slides carefully about the specific things that should be taught to the patient. And for each and every specific type of kidney stones, there is some teaching tips for the patients, because each kidney stone has its own composition, and there are certain types of, especially food, food that is high in that stuff. So we have to teach them about that. So here we have a client has a history of recurrent calcium oxalate urolithiasis, kidney stones. What mineral will most likely to be restricted in the client's diet? So this is calcium oxalate urolithiasis, and the answer for this one
Calcium?
it's actually sodium.
Oh, no.
Sodium. Now, even though or while the most common renal stone is made of calcium oxalate, the sodium restricted diet may be prescribed for the client the sodium restricted diet may be prescribed for a client with recurrent urolithiasis, because when there is an increased sodium intake, that will contribute to increased excretion of calcium in the urine. So sodium restriction, low sodium, may lead to more calcium excretion in the urine, and that would increase calcium deposition in the urine and calcium and stone formation. So the low calcium diet, we know that patients will be on low calcium diet and lowering calcium intake it's not even advisable. We don't usually advise patients to not to eat to consume calcium. But the problem is with the other factors like oxalate, other phosphate, and so or uric acid, and so because when we looked at the evidence-based practice, they found or research suggests that the administration lactate orally should precipitate oxalate in the GI tract. That will reduce the risk of developing renal calculi by reducing urine excretion of oxalate. The other minerals listed are not typically restricted in the diet on the client with urolithiasis, phosphorus or calcium or magnesium. Most of the time, you'll find that this kind of sodium restriction may be prescribed for the client with recurrent urolithiasis because more sodium, this is high sodium, like sodium, more than like 2 grams, because recommended daily allowance for sodium is 2 grams. So high sodium diet may precipitate calcium stones because of the high sodium result in more calcium excretion in the urine and more calcium deposition and more likely or high likely for stone to form. So it's the high sodium diet may increase the calcium excretion in urine and stone formation. So that's why patient with a high tendency or with a history of kidney stones, they will be on a sodium restricted diet. So if the recommended allowance is 2 grams, they should not exceeding that 2 grams. Higher than 2 grams can result in high sodium diet and then result in more episodes of stone formation. So high sodium can result in high calcium excretion in the urine and kidney stones. So that's why these patients will be on low sodium diet. Now, which of the following are appropriate dietary restriction instructions for the client recently diagnosed with calcium oxalate? So I recommend everyone to go back to these slides and read about the specific type of food that is high in, go over which one for purine, which one for oxalate, which one for specific type of or uric acid, and we are going to advise the patients to restrict that type of food in their diet. So this patient their body has a tendency to develop the oxalate kidney stones or renal stones or calculi. What would you advise them to do? What about number 1? Good?
Yes.
Yes, absolutely. Yeah, we have to. So increased fluids are desirable because they will dilute the concentration of the urine and promote excretion of minerals. Because again, number 1 risk factor is supersaturation of urine. So fluids is going to dilute the urine and decrease the concentration of urine, and that would contribute to promoting the minerals to pass through and not to develop the kidney stones and clump together and could form the stones. And it will allow also forcing the excessive fluid. So what about daily cough and tea are appropriate source of fluid in addition to water?
No.
No. When we say fluid here for this specific patient, it is water only. They can drink. That should not be drinking too much of these kind of coffee or tea. But to the point is that they should at least consume the 3,000 or 3 liters, and then if they want to drink other stuff, that's fine. But number 2 is not a good answer. Now 3.
Yes.
Yes, I mentioned that earlier about to take the calcium lactate supplement each day, and a daily calcium lactate supplement is appropriate because calcium is necessary to bind in the digestive tract with oxalate and keep it from entering into the blood and then into the renal system. So it will prevent it from forming the stone. So it will catch it in the GI tract, right? So the calcium lactate will catch that oxalate in the GI tract and prevent it from going or be absorbed and get into the bloodstream and to the kidneys and urine and so forth. So it's kind of stopping the problem from the beginning. So that will be good for number 3. Limit your daily intake of sodium.
Yes.
Yeah, we can do that. But remember that this is an oxalate. It can be true or not highly recommended, but that's fine. With 4, you can say 4 also. What about 5? 5.
No.
No.
If you go back to that slide, you will find that most green leafy vegetables, especially like, for example, spinach, okra, tomatoes, asparagus, spinach, chocolate, nuts, coffee, tea, all of these things they have oxalate. So 5 is not good. Limit your intake of tomatoes, nuts, and coffee. Yes, right? So we can go with 1, 3, 4, and 6. Even 4 is kind of questionable, but for me, I'm fine with 4 either. I mean, in addition to the other 3, sorry. So after urolithiasis, so make sure that you understand the risk factors, how to eliminate or how to reduce the frequency of kidney stones. Had known that this patient had developed stones in the past and had a history of the stone or calculi or lithiasis, and also modalities to treat it, pain management, and the lithotripsy. Read about lithotripsy. Good amount of section on in the book and also on the slides about lithotripsy and especially post lithotripsy, ESWO, and about the specific type of food to be restricted in certain types of stones. That's all what I expect. And also in addition to the lab values and the diagnostic labs for kidney stones and for UTI. Now, this section, the following or the other half of the session is about the UTI and AGN and pyelonephritis. And the UTI, I believe that covered some of this content in Adult Health 1, 241, and we have 2 different categories of UTI: upper tract UTI and lower tract UTI. So the upper tract UTI, you see here, this is the distinction between, or the landmark between, the upper versus lower UTI. Upper UTI, includes the ureter and the pelvis of the kidney and the kidneys. So patient who had developed the cystitis, which is inflammation and infection of the bladder or urethra, that's lower UTI. So we have upper UTI. What would differentiate or significant or hallmark manifestation that may differentiate between the upper UTI from the lower UTI? One of the major manifestations, given that the upper UTI, it's high vascularized more than the lower section or lower portion of the renal system, the upper UTI usually patients develop systemic manifestations like fever, this spike fever for upper UTI, this high likely more than patients with lower UTI. So that's the difference between upper and lower UTI. So now, what is significant about the development of proteinuria in client with type 1 diabetes? And this one goes over the presence of protein in urine and what it means. So what would be the indication and how would you link it to protein? And I think we went over this, or at least covered this concept at the outset of this class or this session. But let's just reiterate, reinforce this concept about protein in the urine. So if patient like type 1 diabetic patient or patient with type 1 diabetes, and we found that this patient has a proteinuria, is that okay, expected because of whatever, the disease process, or this may indicate something else or complication. What do you think?
Number two.
So it indicates that the client's diabetes is uncontrolled. Well, the diabetes one, what would indicate that this is an uncontrolled diabetes, it may actually but the uncontrolled diabetes, I would know from the A1C, right? I can just go to the A1C and find out. But proteinuria, it's more than that. I think it's more significant than that just diabetes is uncontrolled. It has significant ramifications on the patient's disease process. Something
Number one.
significant, exactly. Something really detrimental to the organs, which is in this case it's the kidneys. So diabetic, what is called diabetic. Remember when we went over diabetes and we said we have acute and chronic complications, and one of the chronic complications was diabetic nephropathy. Patients from diabetes, we have to check and assess the eyes, ophthalmic, right? So the eye problems may develop. They may develop the ophthalmic problems, right? Retinopathy from diabetes, diabetic retinopathy, and also they develop the diabetic neuropathy from neuropathy, like neuropathic pain, and also they develop the diabetic nephropathy. So diabetic nephropathy, that's a primary cause of end-stage kidney disease or failure. So uncontrolled, it may lead to the kidney failure. So a macroscopic amount of albumin in the urine is one of the earliest indication of kidney disorder or kidney failure. And patients usually it's asymptomatic. They won't realize that they have a high high albumin or protein in the urine. So so we have to do what is called the annual albumin creatinine ratio, should be done at least once a year for these patients with diabetes or diabetic. So the protein in urine, it's significant indication to say that patient had, or at least in the process of developing, who hasn't went to that stage, but it's detrimental finding that may indicate kidney failure. So it's an indicator of kidney function, and it's not control of the diabetes. So insulin therapy should not be altered because of the proteinuria. So that's why number 4 is incorrect.
Professor,
Yes.
can you go back to number 6 real quick, please? The previous question.
Previous question?
Yes. Yeah, the select all that apply.
Yes.
I want to know why number 3 is correct, because I'm still confused on that one.
Yeah, remember we said from evidence-based practice, research has found that the daily calcium lactate supplement is appropriate because calcium is necessary to bind, because the calcium can bind with other electrolytes like oxalate. They can bind with oxalate in the GI tract and prevent it from getting into the bloodstream, being absorbed, and then to the kidneys.
Okay.
Good?
Yeah, thank you.
Yeah, sure. All right, so next is the pyelonephritis. So again, we said we have there are 2 different categories of UTIs, upper UTI and lower UTI. So the upper UTI, which includes the pyelonephritis, and the lower UTI like cystitis, infection or inflammation of the bladder. So the pyelonephritis is systemic, given that it's an upper UTI, so its manifestations would include the systemic manifestations or like fever, for example. So these are the difference between complicated and uncomplicated infections. So uncomplicated infections occur otherwise normal urinary tract, but the complicated, usually it's coexistent with other problems, obstruction, stones, catheters, other like diseases or infections. So what is significant about the development of we did that proteinuria, and then now we are going to the symptoms, signs and symptoms that would be expected in patients with cystitis. And in other words, that I believe that you learn about this also in adult health one, about the cardinal signs, like common signs, classic signs of UTI, especially like in this case will be cystitis. UTI, patients with UTI, they always complain of frequency, urgency, and dysuria. Frequency, urgency, and dysuria. That's very common for any client who had developed a UTI. Frequency of urination, dysuria when they urinate, and then urgency as they have the urge to urinate, and sometimes they have nothing to urinate, right? To void. One more, in addition to the frequency, urgency, and dysuria, you can add also nocturia. Urination during nighttime, because at nighttime, anyone can explain why at nighttime patients may have higher tendency to urinate during our sleep? Nocturia. Because the nocturia, patients with supine or recumbent position, flat, right? That's how most, even with high phallus position, but there will be it will be recumbent position, high, the perfusion to the kidneys will be the highest. So because of the gravity, less gravity, high perfusion to the kidneys, and more flow to the blood flow to the kidney, and then more urine collection. So that's why there is more urgency and urination, or urgency. At least there is high urgency during nighttime, and that is nocturia. So you can add to the frequency dysuria and the urgency nocturia. So if you want to go with the FDNU, just remember that acronym, FDNU. So most of the questions with select or apply with when it comes to UTI, either it's the first frequency, dysuria, and urgency. Other questions would include nocturia. So FDNU or FDU. That's the classic signs of UTI. All patients with UTI, they complain of these symptoms. Now the GFR. So going back to the renal function test. The renal function test, that's how we evaluate the function of kidneys, renal function to be evaluated through, as we have mentioned earlier, about the urinalysis. You'll find out about creatinine, the bun, and the GFR. And we said that the GFR is the more accurate, it's more reliable and valid tool or test for kidney function. Next to it will be the creatinine, and the least valid or reliable is the bun. And why the bun is the least reliable indicator of kidney function is because the blood urea nitrogen is that this test, or the bun result, is contingent, or it's kind of will be affected by other factors. If we don't drink enough fluids, then the bun will elevate. There will be an increased bun because of we had consumed a good, like, red meat, or like, protein intake, high protein intake that would result. So there are many factors that may fluctuate or may affect or contribute to the high bun. How many times we have older adults being transferred from nursing home to the acute, like, hospitals, because they have a high bun, and most of the time we will find that the BUN elevated because they have dehydration. Nothing wrong with the kidneys. It's just because they have been dehydrated. So the BUN as a renal function test, but it's not highly reliable indicator of kidney function because it's fluctuate and it changes and elevates and or go down or mostly elevated in association with other factors. Fluid intake, less fluid intake, that will go up. The bun will rise. High protein diet, bun will increase. So there are many factors that may activity, muscle, like muscle breakdown, that will increase the bun. So if we're going with the high indicators or the most reliable indicators of kidney function, you would go with number one is the GFR. Next to that is the creatinine. Now, creatinine clearance also that is equivalent to the GFR. When we say creatinine clearance, it's same as a GFR. The difference between them is that the GFR is a blood test. You can just have a specimen, but specimen sent to the lab in 10-15 minutes, you have a GFR level. However, when you request a creatinine clearance, you have to do what is called a 24 urine hour collection, and you have to wait a whole day to do that. So you have to collect the urine in a jar like for 24 hours, and then you send to the lab for that GFR to be to find out about GFR. So again, the GFR, that's a blood test. The creatinine clearance, that's a urine collection, 24-hour urine collection. Now, the difference between them is, as they are, they are, we can use them as synonyms, or they are kind of not the same, but they measure the same thing. The frequency or the speed of our body in terms of, or our kidneys in terms of clearing the creatinine from our body. So it's called creatinine clearance, same thing as GFR. So both of them reliable indicators of kidney function. When it comes to the GFR, it's the highest number is 125, which is the perfusion. Glomerular filtration rate, which is the rate of filtration within the glomeruli, and it goes up. The highest is like 125 mLs per minute. That's how much of blood is going to be filtered into the glomeruli. Now, how much urine will come out of that 125? It's only 1 ml urine. Now, the filtration, which is the GFR, filtration rate, there is a cutoff. How many times do you go to patients, like review patients, urinalysis and GFR and blood and chemistry, you'll find that the GFR is, as long as it's over 60, it's within, it's all what that record would say or finding would say just the over or above 60. So any number over 60, that's desirable and that's the acceptable. However, that the less than 60, it's not good. And it's less than 60 means that we have to find out what about the exact level or the in terms of the GFR, it's less than 60, because that would indicate that there's a kidney dysfunction. So again, the cutoff for GFR is 60, number 60. And a number over 60, we don't even know about it because the lab will never provide us with the exact number. Or what they're going to provide us for all patients who had a GFR less than 60, it will say 59, 50, 30, 20, 10, 12. It will be indicated and spelled out in the medical record. As long as it's over 60, kidneys are good, healthy, no problem. So that's the cutoff for GFR. Any number less than 60, not good. So that indicates there is a kidney dysfunction. So the creatinine, the normal ranges of creatinine, it's 0.6 up to 1.2 or 0.7 up to 1.4. So we can calculate also creatinine clearance can be calculated right from the knowing, or if we have the urine creatinine from the 24 urine error collection, and if you can get that from the lab, and when you measure the urine in over 24 hours, then we'll be able to find out about that from the lab. And then if you have also from the chemistry or from the urine volume, and then the serum creatinine. So once you have these three components, then you'll be able to, or elements, then you'll be able to find out about the C. It's called the acronym is going to be the CCR, creatinine clearance. But again, this is equivalent to the GFR. So when we review the urinalysis, the UA urine analysis, then we are looking or trying to because urinalysis, you can diagnose UTI just looking at the urinalysis. And the most indicator of finding from urinalysis results or findings is going to be the leukocyte esterase. The presence of white blood cells and leukocyte esterase, it's the, I would say, number one indicator of UTI. Once you reviewed or you go over the UA findings or results, and you find a leukocyte esterase, high white blood cells and leukocyte esterase, that's highly likely that this patient had developed a UTI. Now, sometimes it depends on the school practice or protocols. Sometimes it depends on how people or even practitioners, they will say, okay, that suffices. Well, we have symptoms. Patient is symptomatic, and there is leukocyte esterase and white blood cells in the urine. Then we'll treat patient with antibiotic based on these results. Others would say, no, I'm going to do further investigation and do more testing, and I request for a CNS, culture and sensitivity test. So we need a sterile specimen of urine, send it to the lab for CNS, culture and sensitivity. Now, the result of the culture and sensitivity will come back, indicate or provide us with some information. One of them is if there is any, because they are going to have like a jar and agar, and then they will grow bacteria, and we'll see. They will find out about the growth of bacteria, and they will find out if there is any isolation or isolated microorganisms. So sometimes you have one or more, or microorganisms will be isolated. So isolated microorganism number one, number two, but most of the time it's an E. coli. Most of UTIs are caused by E. coli bacteria. And the number is very important. When you get the results, the final results, sometimes you get the preliminary result, and then the second day and the third day or fourth day, get the final result of the CNS. When you get that, you're going to review it, and once you see this number or over 100,000 CFUs, that's significant for a confirmed UTI. The presence of the E. coli, it's way higher than 100,000 CFUs. So we're going to treat. So depend again. Some practitioners will treat without doing the CNS. Others would do, further testing for CNS. Both cases, you are going to treat this patient with antibiotic, but the CNS is good. Why? Because part of this analysis of the findings or the report from the CNS, number one, you will get the isolated type of bacteria. Second, it will provide you with the different types of antibiotic in which that either it's resistant or it's sensitive. So we are going to exclude that bacteria that is, or antibiotic, in which that the bacteria will be resistant to that, right? To that antibiotic. So we will get the antibiotic or select the antibiotics in which that this bacteria is very sensitive and it's not resistant. So that's good about the CNS, that we can select the appropriate and effective or most effective antibiotic for that patient. Now, decline is in kidney failure is to have a serum BUN level determined. What will this diagnostic test measure? So in other words, that if you go back to the difference between the creatinine, the BUN, and the GFR, creatinine clearance as indicators of kidney function, what the BUN indicates, what tells you about what? What is that? What is the BUN? blood urea nitrogen. And that has to do with some things that I mentioned about why the bun is not reliable, highly reliable, like reliable or valid renal test or indicator of kidney function, because of the factors that may fluctuate and change the bun.
Is it two?
Exactly, because urea is an end product of protein metabolism. Remember that when you eat too much protein, the bun will elevate. That's the good thing, is that eating too much protein, especially animal protein, try to drink as much as you can, so the water is going to flush it out. Otherwise, the bun will increase. So in kidney failure, the kidneys cannot clear all of this bun or urea from the blood. So the creatinine and the bun level will be elevated. So that will be things that when we test the patient's blood levels or renal function test, we do it always, especially with patient in acute or chronic kidney disease, we will do the renal function test, the bun, creatinine, and GFR. And you know that the C-reactive protein and the ESR, these two are non-specific, but they are always elevated in all or different types of inflammation, but they are non-specific. And the specific gravity, when questions with a specific gravity, it's a test of the urine that would assess the ability of the kidneys to concentrate the urine. Is it diluted? So specific gravity of the urine specific gravity, it tells us if the urine is concentrated or diluted. So when reviewing the result of the kidney of the client urinalysis, which information indicate that the nurse should notify the healthcare provider? So like abnormal lab result or finding should be reported. Because you didn't, I don't think you have reviewed one over the reference ranges or like normal within ranges, normal ranges. So the normal pH range in urine, it's 4 to 8 for urine pH, 4 to 8. So 6 is within range normal, right? 6.5 is okay, it's normal. Now the Highland cast, almost like few of these Highland casts is present in all different types of urine specimens. Most of the time, it's not significant. It's not that, Highland cast is always present, always be, few of them can be found in every single, or most of the urine specimens. The white blood cells, the normal white blood cells is usually in urine between 0 up to 5. That's normal. So the only one that is out of range is going to be the red blood cells. Red blood cells should not exceed, in urine, I'm talking about urine, should not exceed number 4. White blood cells, not to exceed 5. Red blood cells, number 4. So 5 to 10, that is high. Yeah, and the presence of the red blood cells 5 to 10, because this is microscopic. When you do urinalysis, this is a microscopic. You won't see, it's not hematuria. You're not going to see hematuria. It's like microscopic, very difficult to see it. So it may indicate, so the presence of a 5 to 10 RBC, red blood cells in urine, that can indicate the bleeding and should be reported to the healthcare provider. Next one is at 9 a.m., 24 urine hour collection is started. And this is the practical question about, to make sure that this is the adult health one question. The mechanism or the, how would you collect the 24 urine hour collection, the right or the proper way of doing it. So the proper way of doing that would be which one? Did you cover this in adult health too? One? Adult
Mhm.
health one?
I think so.
Yeah, I mean, that's the fundamental, question.
Always
Yeah.
discard the first.
Always discard the first morning specimen, and then you collect the urine for the next 24 hours,
You
and make
too.
sure to void before the collection is completed at 9 a.m. the following day. Number 2. That's a classic, just to know how this procedure being done or collected. Sorry. Okay. Now, Klein is being the answer was number 2. Klein is being assessed in the clinic for possible UTI. So before you send the urine specimen to the lab for UA, you would collect a small amount of urine to perform a dipsticks test. So which finding indicated the infection is present? I went over this, right? Leukocytosis.
We said it
Right?
was leukocyte.
Leukocytes.
Yes, good. So leukocyte, or if you see a leukocytes, or leukocyte means white blood cells, or sometimes leukocyte esterase. It's more specific than more leukocyte. So it's leukocyte esterase, which is more the fragment of the white blood cells when it dislodged from white blood cells. So it's either leukocyte, if you see leukocyte, or leukocyte esterase, either or both, elevated indication of UTI. Nurse understands that uncomplicated UTI in females are more commonly caused by which organism? And I also went over this
We said it
many
was E.
times.
coli.
E. coli, exactly. E. coli most of the time. Yeah. So the treatment Bactrim, which is it's a brand name, but the generic name is the trimethoprim sulfamethoxazole. The trimethoprim sulfamethoxazole is the Bactrim. Because Bactrim is the brand name, or it's a trade name. So the macrobid, macrodantoin, which macrobid also antibiotic or for UTI. Cipro is the ciprofloxacin. That's the generic name for Cipro is ciprofloxacin. Levaquin also it's a brand name for the generic name levofloxacin. So the ciprofloxacin or levofloxacin, floxacin as a suffix, it's the antibiotics under which category of antibiotics? They belong to a classification, the family of antibiotics called, what do you call that family? Fluoroquinolones. Fluoroquinolones. Now, the fluoroquinolones, they are good. They are very effective, especially the ciprofloxacin, to treat UTIs. But the problem here is that if you run into a scenario and the patient is older adult, try to avoid the fluoroquinolones like ciprofloxacin or levofloxacin or anafloxacin family. Fluoroquinolones, they are not good for older adult patients. Elderly may develop tendinitis from that, tendon inflammation, and sometimes it's not just Achilles tendon in in the lower extremity, like in the patient's foot, the Achilles tendon, and also all other tendons all over the body. So generalized tendinitis, and sometimes severe, may result from prescribing fluoroquinolones like ciprofloxacin or levofloxacin to older adult. So older adult population will try to avoid that from prescribing these antibiotics for them. So because of the tendinitis. The pyridium, it's more of cleansing. It's like sterilization of the urine and renal system, and the side effect is that it will change the urine color into red color, and that's normal. We have to teach the patient not to be scared because that will, change the urine color, become reddish urine colors, and then they may also develop hemolytic anemia as well. These are some side effects of pyridium. Nitrofurantoin, also very effective. That patient should avoid sunlight to protect the skin. So the acute pyelonephritis is the upper UTI infection, and there are pre-existing factors or conditions that may precipitate the infection. Upper UTIs, the infection of the pelvis of the kidney, and it's like obstruction from the PPH sometimes, or if there is a stone, kidney stones, the stones, or patients who had a long-term use of a Foley catheter, like in long-term facilities, and have a Foley catheter, that they may develop upper UTI. These are the manifestations in which that patient will have a systemic manifestations: chills, fever, vomiting, malaise, flank pain. All these are in addition to the classic signs of UTI, like dysuria, urgency, frequency. The controversial, the CV tenderness, that's important. Because we have a question about this. The patients, they tend to develop the pyelonephritis and they expect to have recurrent episodes. And recurrent episodes that can lead to recurrent episodes of pyelonephritis. It can lead to the scar tissue and poorly functioning kidneys, and may also lead to the chronic kidney disease from the chronic instead of becoming like acute, after a few episodes become like chronic pyelonephritis. In peds, usually when they develop the AGN, acute glomerulonephritis or acute pyelonephritis, it's usually it's reversible. Like patients will be completely treated from that disease from the first episode. Now, with acute pyelonephritis, women are 4 times more vulnerable to pyelonephritis than men. Which is the same explanation because they have short, urethra, and the explanation why they develop more UTIs, the frequency of UTIs for the same reason. So the question: what is the appropriate technique for assessing the client who has pain and tenderness in the flank area? And this is like general question in anticipation that we will, given that this flank area, there is kidneys, so we have to think of assessing the kidney involvement of some type of disease. So this is like an assessment question, or assessment core, like 235 question. So what would be the appropriate technique? Patient who have a tenderness, pain in the flank area. How would you assess for the CVS? Or the CV, I'm sorry, CV tenderness.
Would it be 4?
CV tenderness, exactly. You would do number 4. That's an exact technique to assess for the CV tenderness. Costovertebral tenderness, you will do exactly whatever you have in number 4. So, because it's just sake of time, just I we'll go to the next questions. So the acute pyelonephritis, these are some of the diagnostic testing and findings from like leukocyte esterases, 85 to 90% specific for not just pyelonephritis, for any type of UTI, all different types of UTIs, leukocyte esterase. And the second one, you will be looking also for nitrite for acute pyelonephritis and all other types of UTIs. Either it's upper or lower UTI, you'll find 2 things positive present in urine: leukocyte esterase and white blood cells, and leukocyte esterase Number 2, nitrite. 95% also specific for UTI, diagnosing patients with UTI. So this is IVP, intravenous pyelography. Inject patient with a contrast media, and then they will do the X-ray to highlight or to outline the urinary tract to find out any abnormality. So the nurse is caring for a client who's going to have a renal angiogram. What's the most important information to obtain from the client before test? And that would apply to the same things that they are doing angiogram or IVP, for example, IV intravenous pyelography.
Allergies.
Allergies. This test requires a radio opaque or the contrast media, the dye, to be injected. So we have to determine if the patient is allergic to iodine or has experienced any type of allergy or problem after receiving that in the past. So any history for allergy should be reported. So the second and last diagnosis is the glomerulonephritis. What's called the AGN, acute glomerulonephritis. So the acute glomerulonephritis is it's not a UTI or infection. It's a disease that is usually results from the patients who had genetic predisposition to develop this disease. It's or maybe it's, I'm sorry, I'm referring to the disease as an immunologic disease, not genetic. Sorry, it's immunologic disease. In other words, that there is an immune complex deposition in the basement membrane of the glomeruli. So if you look at this, the exact changes within the kidneys. So it's not an infection like pyelonephritis, that's an infection, right, and then becomes systemic like manifestations. Here, it begins with the presence of the factors, which is the antigen. The antigen is going to combine with the antigen antibody with the antibody and becomes like antigen antibody complex. So the antigen antibody complex will deposit on the basement membrane of the glomeruli, and that will result in what is called the AGN. So there might be some genetic predisposition, but this is an not immune deficiency, but immunologic disorder. So immunologic disorder in which that is systemic. In other words, that patient affected by this disease, AGN, it tends to be affecting both sides equally because that's systemic. It's the immune reaction or immune complex in the blood. So both kidneys are affected equally. And it's not like pyelonephritis. Pyelonephritis sometimes right or left side is affected, like one of them just affected, not both at the same time. So it's not. This one is more of that both sides affected at the same time. Pyelonephritis, one side most of the time. So why both sides here? Because with AGN, it's more of immunologic disorder in which that there is an antigen antibody deposition or reaction. The deposit will stay in the or be present in the basement membrane of the glomeruli, and that tends to develop the reaction. So patients with this disease, they tend to have the changes within the basement membrane of the glomeruli will lead to that the glomeruli will become dysfunctional and unable to hold the protein. So a patient will have some type of urine, like hematuria present. Protein will leak through in the urine, so there'll be proteinuria, and they will have a decreased GFR significant decline or decrease in the GFR levels, and they will have lots of, in terms of edema. Why edema? Because they lose protein. Hypoproteinemia or high proteinuria, protein loss in the urine, which means or results in less protein in the blood, that will lead to edema and swelling. So edema and swelling, most of patients with, like in peds, I think that you learned about the nephrotic syndrome. This patient will be pretty much sometimes being misdiagnosed with nephrotic syndrome, especially in children or neonates or peds. In peds, the AGN is very similar in terms of manifestations and symptomatology to the patients or children with nephrotic syndrome. In nephrotic syndrome, they lose more than 4 grams of protein in the urine daily. So that's proteinuria. There will be hematuria, decreased GFR. They will have edema, in which that the edema will be present more in the like puffy face, right? The puffiness or the swelling in the facial edema, preorbital around the eyes, and facial edema will be present, and other parts of the body, but most of the edema will be present in the face. So that would be in addition to also high blood pressure. So patients with AGN, they would have protein loss in the urine, proteinuria, hypo, which will result in low protein in the blood, hypoproteinemia. There will be hematuria, low GFR, and definitely they will have a high bond and high creatinine, and edema, especially the facial edema, and high blood pressure. These are the most significant manifestations of patients with AGN. And again, it's immunologic disorder in which that there is an antigen antibody complex this complex will activate the complement, and it will result in an injury to the kidneys. AGN is very similar to the babies are born or children when they develop the nephrotic syndrome. So here we talk about the edema present in about 75% of cases with AGN, facial, especially facial or the eyelid or the hands, the urine, hematuria, especially microscopic, or sometimes we can see the blood. So that's gross hematuria, microscopic, we don't usually see it. So we have to send the urine to the lab, and that's when we find out about the microscopic. But the gross hematuria, we can, visually can see it. And other manifestations of the, color or the smell of the urine, high blood pressure, and other manifestations like fatigue and GI symptoms. And especially with the GI symptoms, when there is an anorexia, nausea, and vomiting, that's most likely that would be presented when uremia developed. So when there is uremia and high bond and high creatinine, extremely high bond and high creatinine, that's when patients develop uremia from the renal failure, and that's when they tend to develop the anorexia, nausea, and vomiting. Okay, so the question here is so this is about renal biopsy. Is performed on a client. The nurse is assessing the client 4 hours after the biopsy. So what assessment data would indicate to the client, to the nurse, that there is a complication or complications occurring? So post biopsy, then this is very important about, post techniques, certain techniques like post renal biopsy, post liver biopsy. We'll learn about this in adult L3. These nursing interventions are significant in preventing some type of complications. So post renal biopsy is done. You receive the patient 4 hours after. What would be the assessment finding that may indicate that there is a complication?
Or flank pain? Maybe.
Pain is the most serious. Increased flank pain may be an indication of bleeding within the renal capsule. So the hemorrhage is the most common complication because the large volume of blood filtered through the kidneys. And the renal biopsy, there's a quite large needle is going to be puncturing the kidneys. So get through the kidneys, inserted inside the kidney to obtain some type of tissue, right? So to get renal or kidney tissue sample for examination. So the needle puncture of the kidney may cause some blood-tinged urine. Expected, that's we expect that. So, but should not be grossly blood. So a lot of blood, no. So small tinged, like blood-tinged urine, fine. But when it's like gross presence of gross blood in the blood and the urine, that's not should not be expected. So blood tinged urine, no, expected normal from the actual procedure, getting into the renal tissue or kidney tissue with puncturing that with a needle. And this procedure has nothing to do with pulse or left foot or headache. So pain, so increased flank pain may be an indication of bleeding. Another question about renal biopsy is that a patient has a left renal biopsy. Positioning post biopsies is significant. We have to know this about renal biopsy post. What would be the best position right after the procedure? And then for liver also, I will just mention that just to know about liver as well, because we'll cover this in adult L3. So what about renal biopsy? This one is a left renal, kidney. So biopsy taken, patient, you just received the patient immediately after the procedure. How would you position the patient? Or what nursing action should be taken immediately after this procedure? So if you want to start with the vital signs, make sure that post renal biopsy procedures that the vital signs should be or would be checked more frequently than 30 minutes. It will be 5 to 15 minutes during the first hour after this procedure. So 30 minutes is way too much. So it's kind of extended time. So we have to go lower with 5 or 15 minutes frequency, not 30 minutes. Obtain urine specimen from the urinary catheter. So what do you think?
I don't think it's a priority.
What others think about number 2? Correct, incorrect? Why?
I think number 2 is incorrect. Like, if there's no blood, if you're not seeing blood in it, like what would be the point of checking it?
So this distractor, assuming that the patient has urinary catheter, but we don't know from the stem of the question, nothing to do. First of all, nothing indicated from the stem of the question patient has a catheter. Second, the renal biopsy, it's nothing to do with this either. So when you do the biopsy, not necessarily that patient has a Foley catheter. So this is complete distractor. Automatic one. So this is we're kind of adding to the question. We're assuming that patient, nothing mentioned in the question that patient has, or assuming that biopsy, every single patient with post biopsy should have a catheter. No. So what about number 3?
No, I'm taking right side. Oh, true.
Left renal biopsy. Patient should lie on the same, be placed or positioned on the same and placed on the same side. Why? And this would apply also to patients post liver biopsy.
Put pressure on that side so that it can prevent bleeding.
Yes, the liver and the kidneys, they are highly vascularized organs. Blood vessels, a lot of blood vessels there, increased blood flow. There is a high risk for bleeding and hemorrhage. So hemorrhage is a complication that can occur after renal biopsy, same thing as a liver biopsy. Even with liver biopsy, even more worse. So both cases, you have to place the patient right after it for like an hour or two, sometimes go after for a few hours, on the same so for renal should be on the same side, affected side. Here it's left, right? Biopsy then should be on the left side. The right, if this case was the right side, then it would be this. What about the liver biopsy? Post liver biopsy, patient should be placed on one side only because we have only one liver, right? So patient should be placed where? Post liver biopsy.
On the right. On the
Right side, yes. So collaborative management of antibiotics and to prevent the complications about the fluid allowance, urine output plus 500. And this is the equation or the mechanism that we adopted in terms of the fluid restrictions. We said we will get the urine output over 24 hours and then plus 5 or 600 mLs. That will be the patient's fluid intake. If that, the patient will be on a fluid restriction. So that's sodium restriction, fluid restriction. Patient will be on antihypertensive medications, will be on antibiotics, and will be restrict the potassium as well as protein intake. So client with chronic kidney disease. Remember that the acute pyelonephritis or the acute glomerulonephritis, AGN, both scenarios, especially the AGN becomes sometimes chronic, chronic GN, and they eventually, if untreated or undertreated, may result in a acute kidney injury and maybe CKD, chronic kidney injury. So these conditions may progress into become a chronic kidney disease. So a client with chronic kidney disease has been prescribed calcium carbonate. And you'll find that we are going to cover this content of CKD and ESRD, renal failure, dialysis, either hemodialysis or peritoneal dialysis, all that stuff will be, or content will be covered in Adult Health 3. So I'm just giving you like two questions just to go more, because this is a complication, right? Or resultant complication of AGN. So now, client with CKD prescribed calcium carbonate. Why? Or what is the utility of this, or importance, or function, or mechanism of calcium carbonate for patients with chronic kidney disease or end-stage renal disease or kidney failure? Calcium carbonate, almost like all patients with end-stage renal disease on hemodialysis will be in calcium supplement, and especially calcium carbonate, in addition to other medications like EPO, erythropoietin, nitrophos, and others. Phosphate binders like silvamir. What about this one, calcium carbonate? What's the significance of this medication?
I think when the patient has like chronic kidney disease, they cannot remove phosphorus properly.
Yes. So patients with chronic kidney disease, they will have the following: chronic kidney disease or end-stage renal disease, kidney failure result in the following. Or patients across the board will have hypocalcemia, low calcium. They will have hyperphosphatemia, high phosphorus, so high level of phosphorus. And hyperkalemia, high potassium level. So to treat the hyperphosphatemia or high phosphorus level, we can do that by doing we can target it by doing two things. We can get the patient or prescribe prescribe calcium carbonate to take care of the calcium with vitamin D. At the same time, we are going to increase calcium or fix that hypocalcemia. We'll take care of the phosphorus because calcium will bind with the phosphate or phosphorus and will lower it because that will become like a combination of phosphate and calcium. So we can increase calcium and lower the phosphorus doing prescribing calcium carbonate, and most of the time it's calcium carbonate and also vitamin D. So to enhance the absorption of calcium, because the problem is the kidney failure, patients with renal failures, they develop, because we know that the vitamin D activation takes place by the kidneys. The kidney is responsible to activate vitamin D. So because of the vitamin D, it's not being activated, so we have problem with vitamin D, first of all, inactive. So we need vitamin D and calcium, because calcium is supposed to have vitamin D active to be absorbed. So we have to treat hypocalcemia by calcium carbonate. We also can lower the phosphate because calcium is going to bind with phosphorus. So that we take care of the high phosphorus level. In addition, also, calcium by itself is not going to take care of the high phosphorus because patient will be on other medications. One of them is called phosphate binders. And one of them, the most common one, is the Selvamir, like Renagel or Renacal brand names. Selvamir is the generic name for what is called the phosphate binder drug category or classification to lower the phosphate binders, so it will prevent the phosphate from being absorbed in the GI tract. So calcium is very important for patients with renal failure or kidney failure. Another question about kidney damage or failure is that a client with kidney failure caused by chronic glomerulonephritis begins to exhibit the jerking and some muscle twitching. So what additional information is important for the nurse to determine? So when the patients develop the acute kidney injury or a chronic, in this case, like chronic kidney disease, CKD, because the chronic glomerulonephritis, let's say a patient had, resulted or developed the CKD or end-stage disease. Now, with end-stage disease, they have hypocalcemia, they have high phosphorus, they have high potassium level, and hyperkalemia, and they are anemic, severely anemic, because of the EPO, erythropoietin hormones, not being synthesized by the kidneys to stimulate the bone marrow to produce red blood cells, so are severely anemic. So the patient also, from lab values, we are going to review the lab values. It will indicate that is high creatinine levels, 3.5, 4.2, 5.0, higher than 1.3 or 1.2, creatinine level high. BUN is way higher than 21, sometimes over 100. And the GFR is less than 60. And with the CKD or end-stage disease, sometimes it's like 30, 21, 15, 16, less than 60, the GFR. So from all these scenarios, or findings, physiological or lab findings, due to that, or which has resulted from the CKD as a resultant disorder from chronic glomerulonephritis, what if this patient developed the jerky movements and muscle twitching? It's a neuro issue, right? It's a neurological alteration, something wrong with with the nervous system. So because of the toxic waste products. Remember how many times you see patients who are supposed to go for dialysis and they miss dialysis? They become uremic. They have a significant, like become toxic because they have a toxic waste products, especially creatinine and the bone, built up of this weight. This is waste products that are toxic in the blood, accumulating in the blood over time. That's why a patient will supposed to go to dialysis 3 times a week. And each session is about like 4 hour session plus so 4 hour session times 3, at least they need 12 hours required for for dialysis to clean the blood from these waste products. So eventually from the presence of these waste products, toxic material, bone and uric acid and urea and the creatinine, the central nervous system will be affected. So a patient will have these type of manifestations because of the neurological effect. Now, a client with acute kidney injury is being assessed to determine if the cause is pre-renal, renal, or post-renal. And this is the significant question. Make sure that you understand, because we went over this, I believe, in Pathoform, but this is more of a to just review the 3 different types of renal failure. We have 3 classifications of renal failure: pre, renal, and post. Pre-renal, which is intra-renal, the middle one is intra-renal, and the other one is post-renal. So how would you differentiate between the pre-renal from intra-renal to the post-renal failure? Each one of these categories is failure. But how would you identify the risk factors for each type? Any ideas?
Of the options that are on the screen here?
Let's just go over the 3 different types. What do we know about the pre-renal from intra-renal to the post-renal? There are 3 different categories of renal failure. Depends on the result, on the precipitating factors. There are like risk factors for each type or category. So how would you know that, or so when you are going to identify the type of category of renal failure, that is based on the precipitating factor, the contributing factor. Each one has a different factors. Yeah.
For pre-renal, that would be before it even gets to the kidney. So would that be like heart failure?
Which means more of it's not just the organism. I mean the organ, or it's more of the mechanism. Is that the pre-renal, which has to do with the perfusion to the kidney, blood flow to the kidney. So a patient who is being dehydrated and end up with kidney failure, that's a pre-renal because they didn't have enough fluid and blood to get into the kidneys, and then they end up with the failure. So the pre-renal, which is anything to do with the perfusion to the kidneys, heart failure, one of them, CHF, dehydration, another one. So pre-renal, that's any all different factors that may affect the decreased perfusion. What about the cardiogenic shock, right? Cardiogenic shock indicates that there is a decreased perfusion to the kidneys. That's pre-renal. Now, the intra-renal, any disease, any condition, any disorder, any even stones that has developed or occurred within the kidney. Again, anything that affects the kidneys, that's intra-renal. Now, post-renal, all these factors that are passing the kidney from the pelvis down to the ureter, like for example, a patient with a BPH, right? Benign prostate hyperplasia. What type of, and if they had, and they will have hydronephrosis, and they will end up with obstruction and then UTI, and maybe like in a few weeks they will develop the renal failure. So if they develop the renal failure from the BPH, this type is called post-renal because it's passing the kidney and the pelvis of the kidney. The reason, the cause of that. Stone that is obstructing the ureter, for example, it's post-renal. Strictures that is obstructing the patency of the ureter, that's also post-renal. Pyelonephritis is affecting the kidney and pelvis of the kidneys, that is intrarenal. Stones within the kidneys, intrarenal. So for this question, which of the following condition most likely caused it? And that's, again, we said this is a pre-renal. If the cause is a pre-renal, which one goes with a pre-renal?
Heart failure.
Heart failure. And then the last one, last question. It's more, it's about, or the concept of renal or kidney transplantation, organ transplantation. So let's read the question first and see what would be the correct answer for this question. It may seem to, to be very similar to the questions that we usually ask about patients, to encourage them and encourage them to reflect and express their feelings and reflect about the experience and talk more and explore more about the problem, and which implied more of expressing their feelings.
Professor,
Yes.
I'm sorry, what was the answer to the last question?
Which one?
The last one. Was it heart failure?
Yes. Mm-hmm.
Okay, thank you.
Yeah, sure. So this one is, again, and one of the classic questions in which that we're going to encourage patients or clients to discuss the feelings about their, as we discuss the issues with them. So which one is consistent with that concept of expressing or encouraging patients to express their feelings?
Maybe one.
Yes. Yeah. Yeah, exactly. All right. So I think I believe that I covered everything about renal today. So if you have any question, let me know.
Okay, thank you.